Hello, welcome to Enchiridion Chiropractic Training, ECT, where we're committed to advancing the chiropractic profession and empowering you with the latest insights for better patient outcomes. If you're passionate about improving care and staying ahead in this field, don't forget to hit that subscribe button, give this video a like, and share it with your colleagues. Your support helps us reach more practitioners and make a real impact in chiropractic care. My name's Aidan, and in this video I'll be looking at primary versus secondary fixations and our rationale for treatment. The word paradigm means a pattern, model, or viewpoint. In pioneer chiropractic, this viewpoint was usually restricted to considering a subluxation complex resulting from a static articular displacement, that is, a bone was out of place. This concept led to frequent puzzlement when a patient became symptom-free, yet post-therapy static radiographs of the spine showed little change in the original static malpositioning of specific segments. It also failed to explain why patients with well-aligned segments in the static radiograph expressed obvious signs and symptoms of a subluxation complex. In modern chiropractic, the emphasis is on some factor interfering with normal articular mobility. Thus, a dynamic impairment of mobility rather than the static positional impairment. In the modern context, there are two categories of significance in the rationale of joint manipulation. Number one, the hypermobile state, which needs no further mobilization, adjustment, or manipulation. Two, the hypomobile, restricted, fixated state, which requires mobilization to return the joint to normal function. The objective of studying motion palpation and the related concepts of dynamic chiropractic is to know with confidence: 1. Where to adjust. 2. When to adjust. 3. Why to adjust. 4. How to adjust. And 5. How often to adjust. Therefore, one of the primary reasons to learn motion palpation is to determine the quality of existing fixations. A rational approach to adjustive therapy can be outlined after such areas have been found and classified as either muscular, ligamentous, articular, or a bony fixation. During this process, which the doctor should be constantly attempting to verify whether a fixation is primary or secondary, the following general rules should be kept in mind. Only primary and possibly minor non-secondary fixations require adjustment, and they should be mobilized in all directions of restricted mobility. See the gang sign. Primary fixations feel the most blocked, and restricted mobility is demonstrable in multiple directions. In contrast, secondary fixations are not particularly tender except when they are stressed by an examiner in the direction of restriction. Adjusting the secondary fixation will exhibit short-lived benefits. Possibly an adverse reaction may occur unless the primary fixation is corrected first. By adjusting a primary fixation, this will produce changes both locally and elsewhere in the spine. For example, normalizing signs and symptoms expressed at the secondary fixation site. If the primary fixations have been correctly determined and adjusted, the treated articulations should exhibit increased mobility on the next visit, and fixations judged as secondary should have spontaneously improved or disappeared. General spinal mobility, equilibrium, and related symptomatology should improve overall. However, suppose the site of a primary subluxation was misdiagnosed. In that case, the patient will likely report no improvement or even an increase in symptoms on the next visit, and the fixations previously adjusted will be found to be in the same state as they were during the examination on the previous visit. When this latter situation occurs, a determination must be made as to whether the previous diagnosis was in fact correct or not. If a fixation palpates as being completely cleared on one visit and is found to reoccur on subsequent visits, it should not be readjusted. Instead, its cause, that is, a primary fixation elsewhere, should be sought. If the fixation does not clear entirely during that office visit, it should be adjusted on the subsequent visits until full mobility is achieved. Most patients have more than one primary ligamentous or articular fixation. We first try to adjust the most fixated or least springy motion unit. As the muscular fixations spontaneously normalize, a second or even a third motion unit is adjusted to influence other muscular fixations. This allows the inflamed joints begin to heal, the biomechanics improve, there are fewer aberrant joint insults to both the spine and locomotor system. Obviously, this is not a rigid concept. What we're merely trying to say is you must start somewhere, and this is where we have found the best results. And hopefully, when you come on our course, so will you. Thank you very much for watching the video. Don't forget to leave a comment. I look forward to seeing you again soon. Bye-bye.